63-year-old male. He came with complaint of straining while passing urine since 3 months, and during health checkup found to have serum PSA, total serum PSA 77.
Okay. So I want to know his full history regarding his LDPS. So is this only straining or poor flow?
Your voice is less, Kamras.
Yeah, you can hear now? Yeah. Now I want to know his complete presentation.
Okay.
Apart from straining.
No other positive history. There was no other history of LETS, weight loss or loss of appetite.
Okay.
No history of hematuria, pain abdomen or burning micturition.
Okay.
No history of respiratory distress, bone pain, jaundice.
Okay. Any previous history of any instrumentation or catheterization?
No.
Okay. No acute urinary retention?
No.
Okay. I want to know about this diabetes, hypertension, any?
No positive history.
Okay.
In past history, there was no history of surgical intervention in past. No history of diabetes, hypertension, tuberculosis. And he was smoker for 1 year.
Okay.
And there was no history of alcohol consumption.
Okay. Just I'd like to know the physical examination, the spinal and DRE examination. Yeah. Okay.
Raj,
yes, sir.
You are asking for so many things. Can you please tell us why you wanted each of those things?
So he's a 63-year-old male.
Okay.
63-year-old male, sir. So he's straining to void.
Correct.
I like to know about the prostate-related symptoms.
No, your next question was, how is the flow?
Yes, sir.
Supposing the flow was good and he was straining.
Yes, sir.
What does that mean to you?
Can be a vesical calculus also.
Vesical calculus. Vesical calculus can be anything.
And stricture urethra. So
again, can be anything.
Yes. That's why I asked all the histories about everything is negative history.
Once the person is straining,
okay,
it is clear that there is some obstruction.
Some of sir.
Correct?
Yes, sir.
Either that or there is detrusor dysfunction.
Yes.
You're not able to. Don't you think that in all these cases the stream is going to be poor?
Yes, sir.
What is a more relevant question you should have asked?
I should ask for constipation also, sir.
What else related to the urinary tract?
Increased frequency of micturition, but everything is.
Yeah, no. You should have asked. They didn't show and you didn't ask.
Yes.
The frequency of micturition, whether there is any pain, whether there is any post-void dribble.
Yes.
All this. See, the examiner is not just looking at you making a diagnosis.
Okay.
The examiner is also looking at you to see whether your approach is systematic.
Okay.
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 So anybody presenting with lower urinary tract symptoms, you will go through systematically. You've already got a voiding symptom.
Yes.
Now all other voiding symptoms become secondary.
Okay.
But we don't have any history of storage symptoms.
Yes.
Right?
Yes, sir.
Now let us say the person had a frequency of 10 per day and 4 at night.
Okay.
And was training to pass urine.
Okay.
No, not okay. Then what would you think of?
Again, I would think of prostate-related BEP.
Why does he have frequency?
You can have both irritative and storage and voiding rest.
May have.
Yes.
What else?
And if it is associated with the pain, then we have to think about even.
Yes, these two. Don't add things.
Okay.
I'm saying he strains to pass urine, and he goes to the bathroom 8-10 times a day and about 4 times at night.
So I need to ask about the urine volume, how much is voiding also.
I want to ask about urine volume. What else do you want to ask about?
And a sensation of incomplete voiding.
Very good. What else?
I want to ask about hesitancy and the intermittency.
See, all those were covered. It doesn't matter if somebody is training, whether he's training with hesitancy and intermittency or straining. Otherwise, the pathology is likely to remain the same.
Okay.
The lesions might be different, but the cause is likely to remain obstruction. Correct?
Yes.
But what else do you want to ask? You said you want to ask about frequency, you wanted to ask about volume voided.
Sir, he had only straining to white, sir. No other low impact.
I'm asking Kamraj. He is discussing, isn't it? See, important accompaniments to frequency could be urgency, urgent
Contents.
Okay.
Okay.
Many times you'll find that people who have either organically or functionally small capacity bladder will say they're straining because they feel the urine they've passed is not enough.
Okay.
But if there is urgency, urge incontinence, then you know that you're also dealing with what? What are you dealing with? If there is urgency, urge incontinence, frequency.
It may be overactive bladder also.
Could be an overactive bladder, or it is a functionally low capacity bladder. It could also tell you there could be a vesical calculus. Correct?
Okay, sir.
See, pain is not the only symptom in vesical calculus.
Yes.
Yes, if this is associated or if the void is triggered by pain, then you can say vesical calculus.
Okay.
Pain absence doesn't mean it is not vesical calculus.
Okay.
Okay, so when you finish this asking for symptomatology or presenting this, here you ask, but there you'll have to take the history yourself. These are things which will be important to tell the examiner that you're systematic in lower urinary tract symptom evaluation.
Okay, sir.
Okay, what else do you want? They've put up something here. Anything specific you want to know in this slide?
Since the PSA or the master check with the order done is 77, sir.
Sorry? No, in this slide. In this slide,
Yes,
is
sir.
there some information where you want them to be more specific? Or when you take history, you'll be more specific.
Bone pain, I want to ask specific which part of the bone pains.
Start from the first line and then come down.
Yeah. No history of other, already they've told sex. So,
Okay.
and weight loss. Weight loss is, we should be, what you have to see whether it's a significant weight loss.
That's okay. I mean, I accept. A person who's got lower urinary tract symptoms, if he has abdominal symptoms, what are they likely to be?
Then you have to think about in terms of any.
What do you have to think of? What is it likely to be?
Any
what symptoms are they likely to have in the abdomen?
Any nodal involvement or.
Sorry?
Nodal involvement or any visceral metastasis?
Nodal involvement, the symptom are there. What symptom? What is the patient likely to feel and tell you, I have got this also? Or you will ask the patient, do you have this? You don't ask the patient whether you have nodal involvement.
Any pain abdomen section?
Pain abdomen, they said anything more specific. Flank pain,
Okay.
correct. And a palpable mass.
Okay.
Whether he is palpating any mass. These are two things that a patient might volunteer. You might say, I have pain on the left side, near my back. Okay, let's move. So don't jump. You might know the minute you jump like this, the impression you give is that you already know the case.
Yes.
Sir, can I add here?
Yeah, please.
We've gone through this many times. Lower tract symptoms. you complete your voiding symptoms, you complete your storage symptoms, you complete fluid intake, bowel, and then complete burning and hematuria. That more or less will cover all the lower tract symptoms. If there are specific issues, you need to probe into that further. If there is frequency with urgency, then you ask of voided volumes and all that. But you have to learn to structure your lower tract history. It's very mathematical. And this is for you also, Sambhaji. No other LUTs is not a way to present. Okay?
Okay, sir. Okay, sir.
Carry on.
What difference would this make? You wanted to know whether he had retention. What if he had retention? What if he did not have retention?
It indicates any previous history of LUTs actually.
Comrade, see, when you present a case, you should ask questions at the history stage which will contribute to the diagnosis or improve your ability to arrive at a cogent diagnosis. Okay. Somebody who's training to pass urine, whether he's had retention or not, does it change the possibility of whatever he's got?
And even the management line will be same, but it indicates
Yeah. So that will come in the past history, not in the history of presenting complaints. You get it?
Yes, sir.
And many times you can save time by eliminating this kind of questioning, which is repetitive.
Okay.
Once you say he has had no other urinary symptoms, we understand there is no retention, no catheterization, etc., etc.
Okay.
Okay? Let's move on.
No history of surgery in the past, no history of.
What history would you be interested in? They say no history of surgery in the past.
Any pelvic surgery, rectal surgery, I want to know, sir. Because
Okay. What else?
even any spinal surgery,
Yeah. So these are the two things, right? Surgery in the pelvis or on the urinary tract and spinal surgery. Can any other event cause similar symptoms other than spine and the lower urinary tract? No intervention, but please be residual symptoms.
even surgery for hemorrhoids can have.
So they may not have operated. No surgery might have been done, but some event occurred after which he's got these complaints. So that's why Manish, Dr. Manish said right in the beginning that you have to ask for constipation, anorectal symptoms, and so on. Now, what the proposition I am putting to you is, he's got all these symptoms.
Yes.
They're asking for surgery. You ask for thyroid, you ask for spine surgery, you ask for pelvic surgery.
Okay.
Agreed. Is there any other event, not surgery, event, after which he could develop symptoms like this? He might not pay much attention to it.
Yes. Constipation or abdominal fullness.
Sorry?
Constipation or abdominal fullness.
Kamraj, I think you're not getting my point. Any event, something which happened then, and after that, he's got this constipation, abdominal fullness, and all that go over a period of time. A watershed moment, this happened, and after that, I'm not able to pass urine without straining.
Any drug history we have to ask.
No, I'm talking of event. Event.
Yes.
Could he have an injury to the perineum?
Yes, but that part of the, we consider the part of the surgeries.
No, why? He may not have had any surgery. Yeah?
Oh.
There are so many people who get perineal injuries, blunt injury to the perineum, and go about life as if nothing has happened until they develop urinary symptoms, if they do. Okay? Comrade, don't agree, is it?
Yeah, accept, sir. But you asked most
See,
of it.
if somebody comes to you with a history of having surgery following perineal injury,
Yes, sir.
then you know what it could be. But a perineal injury can produce urethral obstruction without the patient connecting the two,
Oh,
if the obstruction is not significant.
okay, sir.
Yeah. Let's move on. Why did he start 1 year ago smoking?
Yeah, it's his personal choice.
Personal choice. At 76, will somebody start smoking?
Maybe.
What could be the reason? 1 year ago. What happened 1 year ago?
Some personal loss.
No. Was there a stressful situation for people in the world? Huh? What is this corona, man?
COVID.
People have been doing all sorts of things during this time. Huh? It's possible he may have been smoking earlier, stopped, and now again he restarted because of all this. Huh?
Yeah, let's move on.
Why Dr. Mohan asked that question was, I think we need to be inquisitive. 76-year-old man
63.
suddenly decided, it's not that he's going to get you brownie points in the exam, but if you find out something significant, that in 1 year, last year, something has happened to this fellow, that's fine. Huh?
Okay, examination. What are the measures normal? So, non-person. Gently, I like to know. Gently.
Hey, who's this made this slide? You first auscultate for vowel sounds and then palpate for lump, is it? Be serious about this.
Okay, sir.
Okay, who made this? Sambhaji, you made.
Yes, I made.
Put it in proper sequence.
Okay, sir.
Gently, along with the abdomen. Both just as normal. BRE tone normal, grade 2 enlarged prostate non. Okay, rectal examination shows grade 2 enlarged prostate with non-tender and hard inconsistency.
Now, do you want some more information on rectal examination? Supposing you are doing the rectal examination and at first touch, you find the prostate is hard. What further information would you like to derive from the examination?
Any prostatic extension involvement, lateral wall involvement, I want to know. So then any fecal infections there.
Sorry?
I want to know any surrounding infiltration.
No, in the prostate. The surrounding infiltration comes later. And you're talking as if you already know it's CA prostate. Hard prostate need not always be CA prostate.
Whether it is the hardness is throughout consistency or a varied consistency, then any nodules, any extra.
Anatomically, let us assume it's a CA prostate, it's a hard prostate. On rectal examination, what information will help you in planning management? The minute you say malignancy, at some point, management depends on the stage of the malignancy. Can staging be helped by digital rectal examination?
Though it is not specific, sir, but we can tell because of any.
No, what do you mean not specific? If you can see 3 or 2 areas of hardness distributed over both lobes, does it not tell you what the stage could be?
Yes, sir.
Yes or no?
Yes, sir. But
the whole prostate is hard. Want to give you an idea about stage?
yes, sir.
You may not rely only on that. That's another matter. But these are things you have to look for. Because the patient might ask you, can I get my further test done 6 months later when I come back to the city?
Okay.
So you want to know At the end, when you make a diagnosis, the patient might want to know what is it I have, how good or how bad is it.
Kamaraj, if the whole prostate is hard, is it likely to be advanced prostate cancer, locally advanced prostate cancer, or localized prostate cancer? If the entire prostate is hard, is it likely to be advanced prostate cancer, locally advanced prostate cancer, or localized prostate cancer? Which one?
Should be localized.
Localized. Yes, sure. Whole prostate is hard. Your index finger is your guide.
Maybe other differential diagnosis also.
No. We are lacking patient with prostate cancer. You have done a PR. The entire prostate is hard. Is it likely to be advanced, metastatic? Is it likely to be locally advanced, or is it to be localized? There are three different things, no? Which one is it likely to be?
It's locally advanced.
Locally advanced. Can it be metastatic?
Can be metastatic.
Is it likely to be localized?
So it's unlikely to be.
That's the important thing. All prostate is hard. That means your finger cannot actually make out whether SV is involved, whether nodes are involved, all that you don't know. So it could be locally advanced, it could be metastatic, but it certainly is unlikely to be localized. Huh?
Like to know the spinal examination. Hello.
Spine examination was normal, sir. Normal.
Why is it not written? For whoever is preparing slides, all residents,
Yes.
it is also preparation for you about what
Yes,
all is relevant, what has to come in which order, and what is the significance of each of the things that you're putting down on the slide. So don't just jump like this and then verbally say spinal examination was normal. Other than spinal examination, Kamraj, anything else you want? You may want to go back to history now and ask him.
So all notes, everything they told in the negative only.
Sorry?
No. But already in general physical exams, everything is negative. They were.
No, something they have not mentioned because they've not specifically asked, but you're interested in.
I like to know his weight also, sir.
Anything else?
Weight, nourishment.
Sorry?
Nourishment also I want to know, sir.
Lepa, don't you want to know whether he's got any other bony pains?
No, it's mentioned no bony pains, sir.
Pain is okay. Oh, sorry, I'm sorry, I missed it. Okay. Okay. Let's move on here.
HP 13.2, platelet 2.6 total count RBs. Albumin. Yes. The albumin is little bit on the lower side, apart from all other industries are normal.
What is the relationship between hemoglobin and prostate cancer?
Well, there is any metastatic lesion to the bones, it may invade the bone marrow and cause anemia and thrombocytopenia. It's one of
Any metastasis has got one metastasis in the head of the humerus and has got another metastasis in the metatarsal bone.
oh,
So what is the real significance of a low hemoglobin?
one is chronic disease, sir. Another is
In CF prostate, what is the significance of low hemoglobin?
it indicates the one is no, it is told no history of hematuria, and another is no bone.
CF prostate, Kamraj, you're missing the point. In CF prostate, if the hemoglobin is low, what can it mean? There's just one or two things it could mean.
Yeah, one is hematuria, sir, but hematuria is
No,
not.
not hematuria, that would have come in the symptom, isn't it? We are talking about things which are not part of the symptomatology or examination findings, which will have a bearing on this patient's management.
And malignancy per se, it can cause anemia and bone marrow.
Sorry?
Malignancy per se can cause
No,
anemia.
I won't buy that. There is a mechanism for everything.
So, if at all there's a bone marrow infiltration, then it can cause anemia.
So, where are the metastases likely to be solitary metastases? And in which bone?
Severe prostate generally spine and pelvis.
Why do metastases in the spine and pelvis cause anemia?
When if at all they involve the bone marrow and they cause thrombocytopenia and anemias.
No, but why not if it is in the head of the humerus?
The more number
What is peculiar about the pelvis, the pelvic bone? Why is the Jamshidi biopsy done in the pelvic bone? You know, Jamshidi biopsy for all the lymphomas and leukemia. Why do they do it there? Why not take from the head of the femur where you see? Forget the accessibility. Any other reason? What is in the bone?
bone marrow.
Marrow. It's full of marrow. Pelvic bone is full of marrow. And if there is involvement of the pelvis, marrow is eaten up. Iron stores, all that, anemia.
There is low protein.
So,
You said albumin is low. What could be the reason in a patient with CA prostate for low albumin?
again, we have to think it's a very rare possibility only. It may be
Sorry?
rare possibilities. Visceral metastasis can also cause this.
What visceral metastasis will cause low albumin? It would be better than that.
One is it's poor nutrition also.
Nutrition, right. Malignancy.
Malignancy and poor nutrition.
Is it likely to be ordinary type of malignancy, localized prostate cancer, or?
Metastatic.
Yeah, so be specific that he could be having advanced prostate cancer. He doesn't know about it, and therefore his nutritional status is poor.
Yeah, let's move on. Maybe we'll get another case where we can discuss nutrition and related issues in some depth. Yeah.
Total PSA is 72.58 nanogram per ml.
So,
Is there any logic in doing free PSA?
Only for gray zone, we are supposed to do for 4 to 10. So for such a big high value, no need for doing free PSA.
What is your inference from this PSA of 72.58? What are the inferences you can draw?
More likely, it should be metastatic.
So number one, it could be metastatic prostate cancer. Can it be anything else?
It should be well differentiated.
No, no. Well, okay, it's elaborating PSA, agreed. Apart from it being metastatic prostate cancer,
High volume,
can it be
high volume disease.
high volume,
Dis-
high volume disease, loco-regional. Loco-regional, that means local plus regional means lymph nodes. Loco-regional disease, high volume. You can have high volume disease in the prostate itself. Yeah? And no need to have any nodes also in some of these patients. So it's very variable. All we know is that it's elaborating PSA. And with the PSA of 72.5, it is highly likely to be metastatic. At what level do you think the PSA is very suggestive of it being metastatic?
More than 20, we have to think.
Okay, beyond 20, 25. Right, okay. Right.
yeah, let's move on.
Urine analysis with the appearance of pH 5 albumin.
I like these fine traces of albumin.
Fine cases.
Seeing it for the first time.
pH is 5, sir, apart from, and albumin 5 traces. Apart from that, no other significant finding in urine analysis and urine
Why
culture.
is pH 5? Why is this pH 5?
It's got no drug history, nothing, no significant.
Sorry?
It's got no contributing factors.
No, if, let us assume pH is 5, the reading is correct, what could cause acidic urine? So here again, you'll have to go back to drug history and dietary history to find out what drugs he's taking, whether he had something different the previous day. Okay. Okay. Go on, Conrad.
Reason why he's asking is that this pH of 5 is very unusual. You know, we see it in a different range. pH of 5 is very acidic. Is he pumping himself with vitamin C or some acidifying agents or God knows what, these fellows may be taking. All these vitamins and, medications. So, that's...
Person was normal appetite, post-fight residues 39 bar 50 cc. Prostate is 52 cc. Okay.
So what?
63-year-old males. He came with straining to avoid since 3 months, and master checkup his PSA was 72, 77.
Rectal examination also was positive.
Positive. So yeah, everything favors in
Okay.
metastatic CA prostate. So we need to, his serum creatinine is normal.
Okay.
So we need to first get a pathological confirmation of the diagnosis. For that, I will do a trust-guided prostate biopsy.
Will you do?
I don't want to do any imaging.
You don't want to do any imaging? PSA 72?
Yeah, we need to do a PSMA PET cell.
The general rule of thumb in urology, don't put knife to skin, don't put a scope inside the urethra, don't do anything invasive till you have dotted the I's and crossed the T's. That means you've done every imaging possible. There is no hurry. Get all the facts, then you will be able to discuss with the patient. You will be in a better frame of mind to advise what is to be done and not shoot in the dark. Okay? So get it, there is no hurry. Evaluate.
More than 77, I will go for a PSMA PET.
You would like to go for a PSMA PET scan. Okay. What are the advantages and disadvantages of PSMA PET scan?
The PSMA PET scan is very good for diagnosing all the distant secondaries, distant spread, and even stages, see these local diseases also. The disadvantages will not see the key staging of the tumor. Actually, it's not possible with the PET scan, but shows all the bony secondaries and other lymph nodes and visceral secondaries.
Okay.
And the sensitivity also is good in the PSMA PETs.
You won't do MRI.
Here we want to know the metastatic spread also.
No, MRI will tell you.
MRI is
Between the two, which is likely to give you more useful information?
when we want to know the local regional status, there is
I don't know. You have to decide. I'm asking you.
Since we are suspecting metastatic, so PSMA PET will be preferable to MRIs.
you see, the current thing is that there is a lot of thrust and push for doing PSMA PET scan upfront. However, if you looked at the Australian study, the famous Australian study, where they did PSMA PET, but they restricted it only to high-grade disease. How did they know it was high-grade disease? Because they had done a biopsy. How did they do the biopsy? They had the PSA and the MRI. The advantage of doing the PSMA PET after that is that if you've got the biopsy report with you and it's high-grade, and the PSMA PET scan shows something else, then your treatment modalities may change. In a patient who's got high-grade disease, if you are contemplating radical prostatectomy, your MRI may not show you areas which can be missed, which the PSMA PET will show you, and therefore you want to change track. So, there's still a lot of debate about which is better, which is good. And it looks as though PSMA PET is actually controlling most of the evaluation in patients with prostate cancer. And that is the way it is likely to go for most malignancies, because we are preferring to use molecular markers for all these things. The only disadvantage of the PSMA PET is that it will not show you the local T stage.
Yeah, let's move on. Kamran, you should tell them to move on.
Yes. Any Euroflow, sir? Sure,
Yeah,
sir.
he's got some obstructive bloods.
Point of interest would be whether the Euroflow corresponds to that, his symptoms or not.
Response training patterns.
Corresponds, right?
Yes. Max flow is only 7.7. And
So the first thing you have to look at is the voided volume. Is it adequate for evaluation?
just adequate, so
No,
150.
it's adequate. There is no just adequate. 150 is taken as the lower limit, so it's more than 150. So it's a valid flow study. Is the flow good?
It's not good, sir. It's interrupted and
Interrupted is what he tells you. On neurodynamics, what do you call it? Interrupted is what he will tell you.
typical plateau is not there. He strains and again strains.
It's not a typical plateau. Plateau is not typical.
It's not.
Whether the stream is intermittent or continuous. That's the next thing you look at on the graph. We know it is intermittent if the flow is touching baseline, that's zero, while the void is still on, which you can see at least in two places here. It is touched baseline, right? There is straining or not, we can't say because there are no real spikes for straining. But we also see that he's got a peak after a long pause, which is probably a post-void dribble.
Oh.
See, uroflowmetry becomes critical in patients who are being evaluated for conditions other than prostate cancer.
Yes, sir.
In prostate cancer, you might only do it if you're planning to do just TURP and nothing more. Okay. Hey, let's move on. I'm sure there's a lot of interesting stuff to discuss.
Let's get a prostate biopsy. Okay, 14-core biopsy. So I'd like to know the.
Is a 14-core biopsy the standard?
Yeah, no, 12-core is enough, sir. Double section is.
Any reason why they have done 14-core?
If at all, because they're not done any imaging, if at all the imaging shows any posterolateral transition zone, so peripheral zone, then we can go 14 cores.
Okay. Move on.
Biopsy report. Lesion 4+5. tumor involves all cores with an overall average of perineal elevation %. Okay, so 4 plus 5, 9. Acinar adenocarcinoma.
So what next?
Yeah, I'll go only to PSMA PET.
What did I PSMA put? Okay, let's see what they've done. What was done? Sambhaji?
Bone scan was done, sir.
Okay.
F18, okay. Sodium for bone PET scans.
What is the difference between a F18 and a PSMA PET scan
Yes, sir.
in nuclear medicine terms? In oncology terms, we know something is more sensitive, more specific. Why do they do F18? Why do they do PSMA? Why do we have two imaging modalities for the same disease?
So one is the avidity, sir. Another is the physiological uptake we have to see.
So one is
Avidity, the tissue avidity, and another is physiological uptake changes within the radio.
both depend on avidity. What is the difference between the two?
The physiological uptake will change. Sir. For example,
It's got nothing to do with uptake. It's something to do with the characteristic of the radiopharmaceutical.
one is alpha emitting and beta emitting that.
Characteristic of the, hey, you use a gamma camera, where will you do alpha emitting? Is there any difference in the characteristics, shelf life, or
Half-life.
process of manufacturing?
Half-life is
Shelf life, I said, between PSMA and FDG.
FPG's half-life is more.
அடி வாங்க போறீங்க. Look this up. This can be a theory question, radionuclides used in urology and their characteristics. I have a feeling Dr. Prabhu will put it up next. Okay, Dr. Venkatesh covered this very well. There were two major determinants. One is the cost. PSMA is costlier. And two, the half-life is shorter for PSMA. So it decays rapidly. If a person goes in the evening to the nuclear medicine facility, they may not have PSMA. Okay? Yeah.
Additionally, FDG is also affected by sugars, blood sugars.
Blood sugars, yeah.
So multiple lesions, left frontal bone, left ramus of mandible, sternum, and bilateral ribs, medial end of right clavicle and bilateral scapulae, a few vertebrae, and sacrum and multiple foci and bilateral pelvis, and so multiple bone secondaries are this. So it's PSA is 72.8 and histopathology is Gleason grade 4 plus 5 group of.
You've gone through all this. You've explained everything to the patient. He says, what next, doctor? There are no problems. He came for a master health checkup.
Yes, sir.
He got some hesitancy. That's about all. He's 77.
63.
Oh, 63, sorry. He's 63.
So we have to counsel him, sir, that he has got a.
Correct. Before counseling, we have to be clear in our minds.
Yes, sir.
About what would be correct treatment and what would not be correct treatment.
Yes.
So what do you think?
So it's a metastatic prostate.
Umapa, now, should we leave him alone? These are the questions they'll ask. I'm okay. Can we do this treatment when I get worse? I may not get worse. I have heard that people have CA prostate, but nothing is done for them. Or do you want to be upfront and tell him, no, this requires, warlike effort. to treat?
So
Or will you say, no, we'll go in stages, step by step? What would the treatment philosophy be?
with high volume and high risk diseases, so we need upfront
Why,
management.
why high risk?
Because his Gleason grade is group 5. That's
Patient grade is high. Okay.
more than 2 bone secondaries are there.
Okay.
So this is will constitute a high risk group. And regarding even the bone lesions, it's a high volume disease because more than or equal to 4 bone lesions are there.
Right.
So we need upfront management of his CA prostate.
So you would like to give him aggressive therapy. You'll have to counsel him and say, from my point of view, that means you are the surgeon, you are the treating doctor, that you may have come for a master checkup, but your disease is quite bad. If you don't treat, he will ask you, if I don't treat, what will happen to you?
Patient will death will happen. You have to explain.
Death will happen. Death will happen. But before the death happens, something else can happen.
You can have bone lesions and paraplegia, all those.
Such extensive bone meds, he could throw shower of bone meds in the spinal column, and he could get paraplegia. He may not die from that paraplegia, but his life will become miserable, his quality of life. So we want to prevent that. We want to prevent that. So we want to tell him, no, we would advise him strongly. And you need to encourage him that yes, there are some treatments available. So he will say, how long can I live, doc? How long can I live, you will ask. I have got my daughter to get married in 2 years' time.
Both high volume and high risk disease. So it depends upon the management what we give and how we respond.
Yeah, he's asking you a very pointed question.
What is life expectancy?
In 2 years' time, you think you'll be able to keep me going? These are all serious questions that patients ask. How will you answer this question? For that, you must know the survival of untreated patients with this PSA and this Gleason. And then you must also know the survival of patients with this Gleason treatment and this PSA. What is the most important factor in this patient's history when it comes to treatment? What is the most important factor?
It's asymptomatic.
Asymptomatic. Absolutely right. This guy has gone for a master health checkup and they have found this. So, his chances of pulling along for a longer period of time are much better than somebody who comes with symptomatic bone meds. They are two different things altogether. Okay? So, you would have to encourage him and tell him there are good treatments available. You should start you on treatment. Your quality of life will improve. Your ECOG status is good. Then he'll ask you, what about my flow test? The flow, I'm having trouble. I came in because I couldn't pass urine properly. What do?
Until once we do all this orchidectomy, it may improve also, sir.
Orchidectomy, yeah.
Suddenly you will say, you want to take my testicle out? Huh? You didn't discuss that with me.
As part of management, we have to explain more.
Then you explain all that. The main problem is can't pass urine. So your immediate answer was, I'll do orchidectomy. It's very inhuman.
Part of CA prostate. Part of CA prostate, I'll explain, and that will improve his flow.
No, how will you tell the patient? Your urine flow is interrupted because of obstruction from the prostate. I can open the channel. We'll pass urine all right.
Medical management.
And so you have to discuss with him the option. There are two issues here. One is the treatment of the cancer. The other is the treatment of the outflow obstruction. What is the plus point in the treatment of not treating the obstruction? The plus point in all this evaluation. What is the plus point in not treating the outflow obstruction? You get my question? Plus point in not treating. I'm sorry, I'm being like Nityananda Swami.
Specifically, is there any disadvantage in doing a TURP to relieve his voiding symptoms?
So can I answer this?
No, you cannot. We all need to do some thinking, Kamal. Huh? So let Kamra think. I'm sure he knows the answer. He has to organize his thoughts.
Yes, sir.
If it doesn't, we'll come to you.
Two residual 35 and 350 was there.
350 is the no.
The 35
350 was the voided volume, I think, and 39 was the residual volume.
Yep.
See, one of the things we need to remember about CA prostate, many men will have a flow which is poor, but they seem to be emptying their bladder. It's like any other BPH fellow. Okay? So it depends on how much. So you decide and tell him that, you need to have treatment for the prostate cancer. That might actually reduce the size of the prostate and make you void better. If you don't, then we can address it. But if you have, supposing he had upper tract involvement, supposing he had a large residual urine volume, then you would be, or if he came with acute retention of urine. Huh? Yeah. A famous question that is asked in the exam is in a patient with prostate cancer, if he comes with acute retention, what is the cause? Prostate cancer patient.
Comes with retention.
Acute retention of urine. The PR you've done. First time he's coming. PR, he comes with retention, you do PR, oh, it's hard prostate. What is the reason for acute retention?
Maybe spinal involvements.
One, okay, one may be neurogenic bladder, okay, sorry. Acute painful retention. If you take out somebody's prostate which has got prostate cancer, will everything be only CA?
No.
There will be a benign component, isn't it? So generally speaking, it is a benign component which is responsible for acute retention of urine. That is why in a patient with acute retention of urine due to when PR also shows the heart part, it's better to do a TURP rather than put a trial and give him this, that, or that, because it usually doesn't work. Okay? It's because the BPH component is the one that is responsible in the majority. The incidence of acute retention of urine, painful acute retention of urine in a patient with CA prostate is much less, all things being equal, no spinal problem, nothing, than a patient with BPH. So that is why it enhances the reason that patient with CA prostate, the BPH component is the one that's causing this. Advise them TURP. Although I know there are many people who will put a catheter, give the hormonal replacement and then see whether it improves. So now what are you going to do for this man? In the current milieu, what will be your approach to treatment?
So it's a high volume and high risk disease. So we need to hormonal androgen deprivation, either in the form of medical or surgical.
Right. So first and foremost, he requires androgen ablation. There is no ambiguity about that. Right.
Then chemotherapy, sir.
Chemotherapy.
Yeah, docetaxel we can give. And since it is a high volume and high risk disease, we can add the novel hormonal therapy like insert with our abiraterone.
No. Are you going to upfront give him?
It's metastatic.
Is it going to be a machine gun barrage, or are you proceeding step by step by step?
First hormonal, then we will give a chemotherapy.
Correct. Is it all part of your initial plan?
It's because
or you give hormone, wait, see, then give something, then wait, see.
It's a high volume disease, so we will go for both hormone and chemotherapy.
The thing is that in patients who have got high volume disease, there are two varieties of high volume disease. One is visceral metastasis, the other is non-visceral metastasis. Okay? High volume disease, also you have to look at the grade of the tumor. So high grade disease.
High grade disease.
So these are situations where docetaxel may help.
So high
If
grade
he
disease.
had, yes, so this is how you will argue. He's got high grade disease, sir. He's got high volume disease, sir. He's got no visceral metastasis. He's only got bone. But because of the high grade and high volume, I would like to give him chemo hormone. If he had visceral, then docetaxel is better. Here the question is going to arise whether upfront you want to add on one of these other agents at the same time as
Yes.
hormones.
Yes.
So, God, tell all that. You have to talk about all that, no?
But like
Why?
I told all,
When you discuss all this in the exam, you keep telling the examiner, for this reason this, for this reason this, for this reason this. That's all. Yeah. Don't wait for the fellow to ask you what next.
You're going to, let us say you're going to be asked. If you're not, I'm asking you now, you want to treat this treatment, treat this patient with lutetium or one of those radionuclide based treatments, or do you want to give chemotherapy?
again, you have to explain the cost also. All this.
You first have to make up your mind what you want to give. We will discuss the cost with the patient, patient preference, and so on, and availability. But in your mind, which one would you prefer?
No, currently is lutetium used as the first line therapy.
Yeah, it's used. Sir.
So upfront you will give lutetium for the bone. It is not used as salvage.
Primary you can use it
Okay,
because the more upfront we give, it's more effective.
right. Okay. So that's why you want to discuss the possibilities. Upfront for the bone you will give this, for that you will give this. Yes. Before lutetium and all came, these were the patients who would have had either phosphorus P32 or they had strontium.
Strontium radium.
And then we went on to samarium. Okay?
Radium.
And now we are going to lutetium. You know why these three slowly went out of the market?
Initially beta.
P32 for severe bone marrow depression. Strontium because only one company in the world was making it and it's expensive. Samarium was made locally, but then they decided to stop marketing. So these things are now algorithmic, and it's important to read all this. This patient is in the category of hormone sensitive, prostate cancer, metastatic. Okay, so upfront you want to bang him with everything. His quality of life is good, his ECOG is good, so hit him hard. Hit him hard so that he gets better, and then you want to give him that 2 years because he's going to get his daughter married in 2 years' time. So you could upfront use the radionuclides to target the bone. Remember, if you use it once, there is a remote possibility you can use it a second time also. You can. You don't have to say that I give it once and never give it again. You can. There are situations where you can. So
He says he's got another brother who is okay. Should he get PSA done for him? That brother is 2 years younger. Should we advise him?
what is your advice? Younger brother. You will ask the brother also to get PSA testing done or not?
If the patient is very concerned, you have to tell him to get.
Forget the concern. Man. You have to be concerned about it. Patient has asked you a question. Sir, my brother is there. He is 63 years old. I am 66 years old. Would you advise him to get his prostate?
You will advise him to get it.
Huh? You would advise him to get it. Before that, will you ask any other question?
Any other family history of cancer-related deaths?
Prostate cancer. Forget any other cancer.
Prostate cancer.
Okay? His father could have had. There is a difference between familial prostate cancer, sporadic prostate cancer, hereditary prostate cancer. All are different conditions. So you would advise that his brother get his PSA done. Why?
He may have the same issues, sir, like what he underwent.
What is the risk?
Likely,
What is the likelihood?
very localized prostate cancer. He may have localized prostate cancer where you might offer him
Cure.
possible curative surgery. Not sure. Not sure. You could at least take care of his prostate and then keep him going because of the so-called lead time bias. Okay? Or if the brother chooses to wait, he can wait. Would you advise the brother to wait?
Yes.
Why?
Again,
Brother's PSA is high. Younger brother's PSA is high. Would you advise him to wait? He says that I'm all right, I don't want anything to do. What will be your advice?
same applies to him also. So we have to.
In which situation would you advise him to hold on? You understand my question?
If his PSA is low,
This is not the way. You have to look at the age at which this fellow developed prostate cancer. Supposing this fellow was 80 years old and he's come now with prostate cancer metastatic. It didn't happen at the age of 80, it's happened. So this lead there, he must have had it at it. So you can tell the brother that, you don't have any problem. Your elder brother developed metastatic disease at the age of 80. Maybe you will also develop at the age of 80. So you can see. It all depends on your PSA. If that PSA is sky high, then he is in trouble. But if it is all in this 4 zone, 4, 5, then you can say, okay, let's wait and see. But you have to be under active surveillance. What's another way of sorting this younger brother's problem out? His PSA is borderline. Sorry, we're digressing from this case more.
it is in the.
But I guess we discussed the management. So it's important these other things are discussed. They never figure otherwise.
In the grade zone, we have to go for MRI on this.
No, the answer to that question is that if his PSA is like this, you do MP-MRI. If the MP-MRI shows that he's a pyrad 4 or pyrad 5, you do a biopsy. Because he could have clinically significant cancer. And if he's in the Gleason 3+3, you could put him on active surveillance. And see, okay, he may be having 3+3 till the age of 80 and then he can do it. So, these are the ways by which you discuss a problem like this. There's no, every patient will think of it in a different way, but you must know exactly how you're going to tackle this problem. Because tomorrow you will go out and you will face this. And remember, the patient will shock. Patient will shock. And it depends on with what confidence you address the issue. You must be very sure, this is what I'm going to do for you. Take it or leave it. So what is the management here? What was done for him?
Sir, he was treated with ADT and chemotherapy, sir, docetaxel chemotherapy.
Okay. Any further follow-up on him?
Yes, sir. 3 cycles finished, sir. Now 4th is awaited, sir. Yes. PSC is awaited.
How is it subjectively?
What is the ADT given?
Yes, sir.
What form of androgen deficit?
Religard, sir. Leuprolide.
Okay. How is his voiding symptoms now?
Not.
We forgot, sir, we are only looking at PSA. Huh?
You have to look at that also, no? Because the main problem is this voiding.
Any questions from anybody? Manish has been particularly quiet.
Is he there?
No question, sir.
Oh, you're there.
Hmm.
I thought he's celebrating Makar Sankranti.
no, no celebrations now. So
It is worth continuing to read this management of prostate cancer, everything that's happening. There's huge amount of
it's evolving so much.
it's absolutely confusing at the moment, and but I think we need to keep focus on it.
Sir, my question was that, sir,
Yeah,
sir, I wanted to add something, sir.
Yes, sure.
Sir, why MRI was not done for this patient, sir? Why upfrontly bone, sir, scan?
That's what we also asked.
Staging, sir. We need staging. Locoregional.
No, that's exactly what we also asked. Supposing the suspicion of bone metastasis was low, MRI would be the first thing to do. I guess because the PSA was 77, they wanted to evaluate for bone metastasis also simultaneously, and were not thinking of local treatment for the prostate cancer. Otherwise, Dr. Ganesh explained this. If it is borderline PSA, you have a hard prostate, or you suspect a nodule which is hard, first would be an MRI to look at the characteristic multiparametric MRI, following which you take subsequent decisions, whether you need to get a scan done or whether you start treatment, wait, what type of scan you do, what type of treatment you offer, and so on. The only mitigating factor we can think of here is that PSA was 77.
Yes, sir.
Otherwise, prostate imaging, pelvic imaging would come first.
A lot of things depend also on the philosophy of the individual treating urologist. Okay? Now, this is something that we cannot change. I have in my mind decided that prostate cancer, metastatic prostate cancer, is a hopeless disease. And it's not worth all this rubbish that is going on today. That's my opinion. You can agree with it or don't. Patient has come to me. My advice is you do orchidectomy and go. Finish. Then we'll see what happens to you. Possible. There are many people who are having that for this disease. Exactly. And the fact that he has remained well for so many years with this disease, it is possible that he may respond very well for a period of time. And then say, when he come back, we'll see. Why you want to do all this now? Okay, Baba. That's your philosophy. Patient comes to you, he agrees with that treatment, you go along with that. So this is all very difficult, no?
Got it, sir.
You understand, no?
Yes, sir.
So, and that's why I will do bone scan straight away. I won't do all this rubbish. PSMA, PET, MRI, what is the benefit, man? I don't believe in treatment of prostate cancer. Anyway, he's going to die. So that's the attitude. You take that attitude, you will philosophize like this in your mind. Bone scan has given the answer. I think, no? You won't be taken to court. Prostate cancer, metastatic, treat. So I'm still treating you. I'm still treating you. And it's possible that this guy's bone may disappear dramatically and he may be well for a long period of time. The only drawback is grade of the disease. And we know that if his grade is Gleason grade group 5, then he is in trouble. Then all of them may not respond and that his PSA drop may not be that good. It may never come down to baseline. There are two types of PSA. One goes up and comes straight down after orchidectomy and baseline. The other never reaches baseline. It's always 6, 5, 4 like that. Never reaches. Those are the dangerous fellows. Slowly it will go up again. Has to go. So what to do? Like when it goes up, I'll see. Pathikalam. Kamraj plan. Parklam.
I was thinking of the same thing.
Right.
Sir, one more thing I would like to add, sir. That age limit is 60 years, sir. For further proceeding like molecular genetics and all, 60 years, sir. If patient presents with the age of 60, then his relatives have to, within 60 years, if he comes, then his relative has to go ahead with this evaluation.
Correct. Yes.
See, but here he is asking you. You have not told him to go.
Okay.
He is asking you, or the brother has come along
Yes.
with the patient, and the brother says, should I also get tested?
So, yeah, sir, I like to answer this. In this patient, all metastatic carcinoma prostate has to go through germline mutation test as per EAU 2021, sir. And if it is not metastatic, it is carcinoma prostate less than 60, their suspicion to have in other relatives.
Arey Baba, that is EAU guidelines. Now, where will you develop a germline mutation assessment in my city?
Sir, I try to evaluate. There are not any. I spoke with Onco.
That's what I'm asking. It's okay for Europeans to say germline mutation. Yeah, you can't be done for anything here. So what is it?
Yeah. Here if we have to do, sir, then we are only BRCA 1 and 2 and ATM.
That's all. We can only do that.
Yeah.
And then you know whether that fellow will respond or not to enzalutamide, not respond to enzalutamide. All this. That's all.
Yes, sir.
That's all. What we can do, we will do.
Yes.
One thing is very clear. One thing is very clear. We are not going to cure this man.
Yeah.
We are not going to.
Yes, sir.
If he was 80 years old, maybe he will die of something else. But at the age of 67 with an ECOG of 1 and good heart and everything else,
Yes.
probably going to, come on with metastatic prostate cancer disease. And everything will hinge on how rapidly he responds to the treatment that you're giving.
Sir, I come across one patient which we have done channel TRP in a symptomatic patient who had carcinoma prostate. He developed incontinence, sir.
Okay?
That only want to tell the side effect of doing channel TRP in a carcinoma prostate is incontinence.
Even in BPH, you do that. You tell them that incontinence is a possibility. Right?
Yes, sir.
In CA prostate, the possibility or rather the probability is higher because the tumor can infiltrate this sphincter.
Sphincter.
Okay, so the obstructive element of BPH in the periurethral zone or the transition zone might be the only continence mechanism available.
Yes, sir.
If you take that away,
What is most important when you're doing a resection in CA prostate is not to treat it like a BPH resection.
Okay.
Just open the bladder neck area and a little bit and stay far away from the veromont tunnel. Don't go and do on completion a very little job there. No, nothing. Because these flows will never improve because the whole urethra is rigid.
Okay, sir.
So you just do a channel means channel, just make a hole there. That means at the bladder neck. Mostly the bladder neck and the trigone, if there is infiltration, you take that off. That's all. And stay well clear. In fact, most people advise that you leave tissue in front of the veromont tunnel.
And if the gland is small, sir, only BNI will be enough, sir.
It should be enough, but if the gland is small, why do anything at all?
So obstructive blood symptoms are there, sir. That's why. If gland I find small.
see, you started some treatment.
Something is bladder. These treatments might help it.
Okay, got it, sir.
Okay. Right.
Thank you, sir.
Thank you. Happy.
Thank you, folks. Next week.